everyone, I'm Susan Weiner. I'm a registered dietitian and certified diabetes educator, and I'd like to welcome you to this edition of Facebook Live, where we'll be discussing the connection between diabetes, cardiovascular disease, and chronic kidney disease. Lucky for me, today I'm joined by Dr. Jonathan Winston, who is a nephrologist or kidney doctor, and Dr. Stacey Rosen, who is a cardiologist or someone who specializes in heart and cardiovascular issues, and both of whom are experts in their respective fields. Thank you both so much for joining us today. People with diabetes may have an increased risk of heart disease and chronic kidney disease. The good news is through healthy eating, exercise, and other lifestyle changes, there are a number of positive ways to keep up with your heart and kidney health. Today, we are going to learn more about the link between diabetes, heart disease, and kidney disease, so you can take some small yet very positive steps to protect your heart and kidneys and still manage your diabetes. Before we begin, I'd like to let you know that this program is being held in conjunction with the National Kidney Foundation, Diabetes Sisters, and Unchecked, the National Coalition for Women with Heart Disease. So let's jump right into our discussion. Dr. Winston, can you define the healthy kidney and what kidney disease really means?
Sure. Generally we have two kidneys. Some people are only born with one kidney. Some people donate a kidney. Some people receive a kidney. One kidney is enough to have kidney health. But the kidneys are comprised of a very intricate bed of blood vessels, microscopic blood vessels, all of which act as one unit to filter blood and remove waste products from the blood. So a normal kidney will do that normally, and your doctors can check for that kidney health parameters by blood and urine tests. Kidney disease, the most common cause being diabetes, is when the kidneys just aren't excreting waste products as efficiently as they should. And there are many stages or scales, but clearly why we're here is to discuss or avoid the worst form of kidney disease, which is kidney failure, which is an inability of the kidneys to maintain health, and then one would need dialysis. And there's a continuum of kidney disease leading from normal kidney function to kidney failure. And we want to avoid any kidney disease, but certainly kidney failure.
Thank you. That was such a thorough explanation. And Dr. Rosen, what is a healthy heart versus heart disease?
That's a good question. The heart is a pump at the end of the day, and its primary job is to pump blood to the other vital organs, kidneys, lungs, brain. And the blood vessels that feed the heart muscle are involved in keeping the heart muscle healthy.
Right.
So there are all forms of heart disease, including heart attacks or angina, heart failure, rhythm disturbances that can cause palpitations. But at the end, the overlap between diabetes, high blood pressure, and heart disease often has to do with the damage that elevated blood sugar, abnormal cholesterol, and unmanaged high blood pressure can have on the blood vessels.
Oh, that's very, very interesting. Dr. Winston, can you please talk about the interplay between having diabetes, having heart disease, and having kidney disease?
The normal healthy kidneys are dependent on vascular health. As I said before, the kidneys are an intricate web of microscopic blood vessels. Diabetes and high blood pressure both cause changes in small blood vessels. They get thicker, stiffer, and narrower. So blood flow to any organ is reduced when you have the side effects of high blood pressure or diabetes. So together, having diabetes and hypertension poses a big risk on kidney health and, of course, on heart health.
Wow, so they really do amplify each other when we have all of the diseases, the heart disease, the kidney disease, and diabetes together. Dr. Rosen, what are some of the consequences of having unchecked diabetes and unchecked blood pressure if someone is not monitoring their values?
That's an important question because 80% of heart disease is preventable. And it's preventable by knowing some important numbers. Some of them include your blood sugar. being aware if you have abnormal blood sugar and managing it, lowering it, knowing about your cholesterol level and reducing it when possible, and knowing your blood pressure and managing it appropriately. All three of those numbers are things that each one of us could know, very personalized, and manage with the help of clinicians to be sure that we've optimized those three to minimize risk to our blood vessels and the heart function.
Very interesting point. I don't think that some people really understand what a cholesterol value is and what a triglyceride value is. Can you speak more on that?
Absolutely. Triglycerides are one component, but if you think of total cholesterol in general, the major components that we all talk about is the LDL, which is the low density lipoproteins. We want those to be low. Those are the bad cholesterol. HDL, high densities, we want to be good. And triglyceride is the third component in a traditional total cholesterol panel. Each of those may have a different impact. Interestingly, in the past, we didn't realize how important triglyceride levels were. At one time, we thought that this wasn't as bad when it's elevated as the other types of cholesterol. We now know, particularly for the diabetic patient, or for those with renal insufficiency, kidney dysfunction, watching the triglyceride and monitoring it and appropriately treating it is very important.
And what can somebody do to lower their cholesterol and their triglyceride levels?
Absolutely. The most important thing actually is knowing, and there's too many people who don't know their numbers. And then it's looking at lifestyle changes, food choices, weight management, and it's not an all or none. As little as a small amount of weight changes, some small changes in the foods we choose, moving a little bit more, can have a huge impact. Of course, there are some individuals who need medication to manage these optimally.
All these small lifestyle changes lead up to a big impact on our health. And we don't always have to do everything at once. One small change at a time makes a huge impact. Dr. Winston, can you talk about, following up on the blood pressure discussion, how blood pressure or high blood pressure affects the kidneys?
The blood pressure is a major determinant on how healthy our kidneys can be maintained over time. So high blood pressure damages small blood vessels. If small blood vessels are exposed to high blood pressure for years, these blood vessels don't get destroyed, but they get injured and they react to that injury. And that reaction usually takes place by them getting narrower, thicker, with simply less room to move blood through them. And that's what the kidney is supposed to do. The healthy kidney is supposed to take blood, filter it, get rid of waste products. When those blood vessels are diseased by either high blood pressure or diabetes, they can't do that, and that's called kidney disease.
What can somebody do in terms of lifestyle to improve their blood pressure?
Several things. One is try to be at your ideal weight by exercising, staying fit. Be careful about the foods you eat. Dietary salt is a big culprit in terms of blood pressure, so we should be on a limited salt intake. And also alcohol. Avoid excessive amounts of alcohol. And be careful about how much foods you are eating that are rich in bad fatty acids or cholesterol. So it's exercise, alcohol, weight reduction, salt intake, cholesterol intake, and of course, quit smoking.
And I was going to bring that up
as
well.
An absolute given.
Absolutely. Dr. Rosen, do you have anything to add to that?
Yeah, I think we've seen a lot of interesting new data about the importance of sleep as well, and we are a country that does not. We brag about not sleeping, and we think it's a badge of honor. But the truth, sleep hygiene and having adequate sleep has been shown to have effects as well.
On everything, including our stress management, including stress management. That's a very, very good point also. And turning off our technology sometimes in the evening does help us sleep better, that's for sure. So looking at this great background that you both talked about, as a diabetes educator, I can share that 99% of diabetes care is self-care. People with diabetes need to take care of themselves. They're not always with their wonderful clinicians and may not always have support. Dr. Winston, what do you suggest people do in a positive way to help manage some of the expectations that they may be hearing from us as healthcare providers? So they're not, because diabetes is overwhelming, to feel a little bit overwhelmed in their daily care.
I think patients or individuals really should be doing what we said before. You need to know your numbers. You need to understand what the goals are, be it for blood pressure, for cholesterol, for diabetes. And once you know your numbers, you discuss those with your doctor or healthcare provider and come up with a target. Where should they be and what's a reasonable rate to get there? And then there are these lifestyle changes that we discussed that you can embrace. And I think the challenge is to embrace it. It shouldn't be that we're in food prison. It shouldn't be that if you didn't exercise today, you've done something terrible. But it just is a matter of your outlook that you are in control. Knowledge is king. And you need to take that and embrace it and do the best you can and be in touch with your educator and your physician and see how you are going forward. For most of the things we're talking about, it's not an overnight fix. You can't be really good in March and fall off the curve in February. It's got to be a lifestyle modification, and slow but steady will win this race.
Almost getting rid of the words good and bad.
Oh,
and
yeah.
I saw Dr. Rosen just going like this. So I want you to follow up on how not to use a judgmental approach with the people that we work with and incorporating. They are the head of their own healthcare, as I said. So you could follow up on that.
Absolutely. I think we have all in the healthcare world switched from a disease prevention process to a health enhancement model, where we partner with our patients, our communities, to really identify and optimize ways to stay healthy, as opposed to don't do this, don't do that.
Absolutely. Absolutely.
And I think it's very important that we, dismiss the all or none principle. So some of the food choices don't have to be perfect. Exercising does not mean running the New York City Marathon
Unless you
next
want
year.
to. That's always my line.
Unless you want to. But it means every time you have an opportunity to walk rather than taking an elevator, every food choice that's a little smarter than an alternate is the way to go. And actually being proud of continuously trying to make the right decisions.
And in terms of providers, people with diabetes can seek other providers if the communication you have with your current provider is not really working for you. Dr. Winston, what do you think about that? People searching beyond maybe who their current healthcare team is.
Yeah, absolutely. I would like to think that as a community, physicians are embracing the challenges of better health, but I do acknowledge at the same time that many physicians really, the interaction between a patient and a physician is short. There are certain realities. Yes. It's short. It's perhaps too focused on disease and not focused enough on life. But I think the patient needs to be their own advocate. They need to ask questions. And they need to really know what the issues are. What diagnosis, doctor, do you have for me? And what can I do to better myself?
And I have to add, from the diabetes educator standpoint, no matter how long a person has had diabetes, it's great to ask, tell me about your diabetes journey. Tell me where you are now, because diabetes burnout, when it comes to heart disease and to kidney disease, is a very, very real thing. It's a very real thing no matter where you are along the continuum in your care. Let's go back to the cholesterol piece for a minute and just looking at the different parts of it that you mentioned. Can you talk about modifiable versus not modifiable risk factors when it comes to heart disease and to some of those lipid levels or blood fat levels?
Oh, absolutely, because the beauty is most of your risk factors for cardiovascular or heart disease are modifiable. So your cholesterol level is modifiable. Managing your blood pressure. It doesn't mean that you won't have hypertension or elevated blood pressures, but they can be managed. The truth is, the only non-modifiable is your family history. We can't change that, but it's important to know it. Your age and gender, because As we age, our risk for heart disease goes up. But pretty much everything else, moving more, cholesterol, blood sugar, weight, is all something that is in our control.
And doesn't a woman experience different symptoms of heart disease and of a heart attack than a man?
Yes, and that's very important. Historically, the medical community didn't think that heart disease was a woman's illness. But ever since 1985, more women die every year of heart disease than men. Wow. And part of the challenge is that women don't necessarily have what we call typical, an elephant sitting on my chest kind of pain. They may just feel some breathlessness or fatigue, something that most of us experience every day.
So it's something that we may not even be aware of, and that's very much a real thing, and the symptoms are different than what we typically hear that a man might have. Do those symptoms change if somebody has diabetes?
Yes, that's a wonderful question, because some of the damage that diabetes does to blood vessels and to nerves may make individuals less likely to have discomfort in the chest at all. And in the cardiology world, we treat diabetics almost in a special class. Even if they don't have known kidney disease or heart disease yet, we know that their risk is so high if the blood sugar isn't maintained at optimal levels that we are very aggressive with diabetics.
Interesting. And Dr. Winston, do you have anything to add to that?
No, I agree completely, and the same with kidney disease. We know that diabetes is the #1 cause of kidney disease in the industrialized world, certainly in the United States. And all diabetics should be screened for kidney disease by blood tests and urine tests. There are medication that you should be on, even if you have the most minimal abnormalities of kidney function and you're a diabetic. And we've actually, as a community, as a country, we've made great strides in not curing diabetic kidney disease, but slowing the progression. There's a lot of research going on. There are a lot of clinical trials going on, and we're very hopeful that with a little more time, hopefully just a little more time, we'll find something that really can improve kidney function in people who already have kidney disease from diabetes. Right now, a lot of it needs to come from the patient, the relationship between the patient and the doctor, early identification, medication when necessary, and lifestyle modification.
And a lot of this from the point of providers, as excellent as the two of you are in your field, is communication and language, and making sure that the questions that we're asking upon assessment and upon follow-up allow the person who's coming in to see us to share what some of their concerns are and to not feel judged, so that they can share the information of what's going on in their current world and in their current life. I'd like to follow up a little bit about that, the medication issue. How about people with pre-diabetes who may have kidney disease and heart disease, but we'll start with kidney disease?
So if you have pre-diabetes and you have kidney disease, the two are probably may not be related. I shouldn't say probably. They may not be related. So that needs to be separated. Most people who have diabetic kidney disease have had diabetes for some time, and the kidney disease is a side effect or a complication of having diabetes. So pre-diabetes is essentially a metabolic state where you don't quite meet criteria for diabetes, but you're showing some signs that you might and you should get certain treatment. Kidney disease in that setting may very well be different than diabetes and should be addressed independently.
And how about for heart disease and heart health for the person with prediabetes?
The person for prediabetes, we put in that sort of early warning category, because we do know that that is sort of a stage of elevation in sugar or some other metabolic combination of abnormalities that puts individuals at slightly higher risk. And I think that that is a very important conversation to have with our patients. You know, we joke that nobody would go to their accountant this time of year without being completely prepared. So optimize your doctor's appointment, your clinician, your educator's appointment. Come prepared with your questions. Sometimes we suggest people come with a family member or somebody else.
Great idea.
Because it can be an intimidating time, it's frightening. And really that partnership between you and the clinical team that you put together is really critical for these chronic conditions.
Even write down your questions or bullet points of what you want to discuss. Dr. Winston, does race or ethnicity influence at all people who have chronic kidney disease and diabetes?
Yes, there are definitely very important links between race, ethnicity, and kidney disease, diabetes, and heart disease. The challenge is to distinguish how much of these links between race or ethnicity and disease is genetic, your family history, which you can't change, or environmental, where you live, how much money you may have, what your cultural background is telling you about foods that you eat or foods that you like. So that's still being sorted out. In the United States, African descent, black race, is a risk factor, if you will, for kidney disease. 5 times more black patients develop chronic kidney disease compared to white patients. How much of that is environmental and how much is genetic is still being sorted out. But the data is real and needs to be addressed, both clinically, individually, and as a society.
And the same question, Dr. Rosen, about the heart disease.
Yeah, the importance of separating what is genetic and what is related to social determinants of health or the way that we live is very important. But we have discovered that African Americans in the U.S. are at higher risk for high blood pressure, and they are still teasing out whether this is part of a genetic question versus societal issues, how we live, how we eat. Hispanics in the U.S. are at higher risk for diabetes and the complications. And again, we think that is partially genetic, partially related to cultural food choices and how families exist. Still a lot more to learn.
There is a lot more to learn, a lot more research to be done in the area for sure. If somebody had a kidney transplant, can you talk a little bit about that in a person who has diabetes and is undergone a kidney transplant? What does that mean for them in their current lives?
There is a great question. So, if you're lucky enough, if you're unlucky enough to need a kidney transplant, but lucky enough to get one, it's a great opportunity. And thankfully, 80+% of people who get a kidney transplant are restored to virtually normal health with just having one kidney. We should be doing more transplants in this country. But there are side effects of having a kidney transplant, not right away, but over time. Some of the medicine that we give that are anti-rejection, that help you prevent rejecting that organ, can cause both a little bit of kidney disease and even sometimes diabetes. So people who have a kidney transplant need to be checked and need to be followed. Now, that's pretty obvious. If you have a kidney transplant, you're usually going to see your kidney transplant team or your nephrologist on a regular basis. And if you show any signs that your blood sugars are elevated or your A1C is elevated or your lipids are elevated or your blood pressure is elevated, that needs to be aggressively treated.
And Dr. Rosen, for people who have undergone a kidney transplant and have diabetes, how does that affect their heart health?
Absolutely. Some of the complications or some of the side effects are related to the medications that are required for preventing a loss of the organ. Elevated high blood pressure, abnormalities of glucose, of blood sugar management, but also some of the medications can actually damage the inside of arteries. So we watch those individuals a little bit more carefully for any signs of coronary, the arteries that feed the heart muscle, for any kind of disease that's growing there.
Is that done on regular checkups, or are you looking for certain signs and symptoms that might be occurring?
Regular checkups, again, check those numbers and make sure that optimal lifestyle improvement is done, as well as medications for some people. And then educating individuals with kidney transplants that they may be at higher risk for heart disease,
Right.
so that they're aware of early warning signs.
Looking for the warning signs and having that open communication is just so very important. Very important question. What about people with diabetes who are going through menopause and maybe considering hormone replacement therapy? Can you speak a little bit about that?
Sure, it's a very important, and had been for decades, a very challenging question. Menopause for women is a time that before which they are somewhat protected from traditional cardiovascular risks. At the time of menopause, with loss of estrogen, blood pressure on average rises, lipid numbers on average get worse. For some, weight gain may lead to abnormalities in blood glucose. So it's sort of a time in a woman's life when knowing their numbers, being vigilant, really being aware of opportunities to lower their risk as this loss of estrogen increases their risks is very important.
Oh, it is so important, and it's very important to have that open dialogue with your provider so that you can discuss what all the options are, because there are so many options that are out there. You feel like there are so many changes going on. What do you actually do about them? There's a lot of choices in that. Does that stage affect people with kidney disease as well, going through the menopausal stage?
Not as much, or not as directly. So blood pressure is a big issue. Bone health, which is a major issue, is impacted by kidney disease. So it's certainly doubly impacted during menopause and postmenopause. So it's not a direct impact. There's no direct impact of hormonal therapy or going through menopause and kidney function per se. But again, the risk factors for kidney disease, blood sugar, blood pressure, lipids, those are all impacted.
Thank you. At this time, let's take a few minutes to respond to some of your questions. So if you have a question on this subject, please post it in the comments section, and we'll do our very best to answer as many questions as we can. We have our first question. Dr. Rosen, what can somebody do who can't remember to take their medications every day or needs some kind of organizational tips to do so? Do you have any recommendations for that?
Absolutely. I joke with individuals whom I see in my office about always looking beautifully dressed and on time for an appointment. So I'm a big fan of logging things. So whether it means keeping a diary, either a handwritten diary or a digital one, those pill boxes, putting them next to your toothbrush. I joke, most of us remember to brush our teeth twice a day, brush our hair, do other morning and evening things, and having a buddy, whether it's someone you live with or a friend, to really watch out for each other so that you know that, yes, that third pill at the day that you sometimes can forget, that you actually did take it appropriately.
It's a great idea, and a recommendation that I also sometimes share is to do things in pairs. So for people who don't always remember to check their blood glucose levels, do it in pairs, like with brushing your teeth or with putting on makeup, because those are things that you're not going to forget to do. So if you check in pairs, sometimes that helps as well. How about staying organized with parts during the day that you have to take care of your general health? Dr. Winston, what do you think?
Well, these are very, very challenging issues. And I think the biggest challenge for our patients is that the processes that we're talking about, having high blood pressure, having high cholesterol, even having borderline high sugar, most often is without symptoms. So if we have a headache, we know where to go. We go to the medicine chest, and by the way, we shouldn't be, but that's what we do. We go to the medicine chest and we take some medicine. So dealing with disorders, diseases that are chronic but without symptoms is very, very challenging. So I don't have the one answer, but organization and attention are clearly the major goal. And I think it gets back to what we were speaking about before, knowing your numbers and more embracing the challenge rather than feeling punished and beaten down from it. Because the bottom line is there are a lot of opportunities What we have today in terms of medication, knowledge, lifestyle choices is so much more
Yes.
than our parents had.
Yes.
So think of the opportunities people have today having the same disorders that our parents may have had. We could be living 20, 30 years longer. We just have to do it.
We just have to do it. Another question, Dr. Rosen, if somebody has a family history of diabetes and heart disease, should they look into being checked for heart disease? Would put them at a higher risk than someone who may not have a family or genetic risk of heart disease?
Absolutely. Even though you can't change your family history, knowing it is very important. And sharing that information with your clinician so that they appreciate the optimal way to identify risks, treat them if need be early is very, very important.
Do either of you work with certified diabetes educators as part of your team?
I do.
You
Yes.
do?
We
Tell us a
do.
little bit about your work with your diabetes educators.
So our approach to heart disease, and as Dr. Winston said, chronic conditions in general, means that each person, each patient should have a team. Because each of us can't be an expert at everything. So working together with the patient at the center is the key. So I would never presume to know as much about educating an individual about managing abnormal blood sugars as our endocrinologists, our diabetes nurse educators, and our other nutritionists. So we partner to be sure that patients get referred for programs that are available.
Wonderful.
Data on the internet that's available. As you said, you're managing most of this by yourself at
Yes.
home, not in one of our offices, and being empowered and optimistic and seeing your choices really has an impact.
The empowerment is important, and the self-management education programs are just so important as well. How about you, Dr. Winston? Have you worked with diabetes educators?
Absolutely. And
That's the right answer.
because it is the right answer because, as Dr. Rosen said, that team approach is essential. We've shown that doctors alone just don't do it well. We just don't. We do things very, very well, but not everything well. And we need other people. We need a team approach.
Well, I think that your point before was just an excellent one, that time management is very much an issue. And between physician visits, there is that lag time, and people can kind of fall by the wayside if they're not followed up and then come in with just yesing you and fear of judgment. So it's important not to do that also. What about a person who is feeling very alone or very isolated in their diabetes and with their kidney disease and their heart disease? Are there any recommendations of support that either of you would have? Dr. Rosen?
Yeah, no, that's actually a very important question because some of the stressors, anxiety, depression, loneliness that comes with the challenge of managing chronic conditions can actually worsen them. Whether it comes to not being adherent with recommendations or issues related to depression alone. So an organization like WomenHeart actually has support groups throughout the United States.
Can you speak a little bit more about
Yeah,
WomenHeart?
it's a wonderful, they are called WomenHeart Champions, and they are women who have suffered from some form of heart disease. They're specially trained to lead these support groups, and they are a wonderful opportunity to meet other individuals who are having the same challenges that you have, to not feel that you're in this by yourself. There are also wonderful information online, again, for this self-management, empowerment that goes on and is so important in between doctor visits.
That's so important, as the Diabetes Sisters organization also offers online support and meetup support in communities for people who feel isolated and alone, because let's face it, sometimes family, friends, coworkers, colleagues are not always supportive, but people who may be going through a similar process are great support, and peer support is fantastic and wonderful and understanding for sure. And Dr. Winston, what about in support group for people who have chronic kidney disease?
Well, I'm a strong advocate of the National Kidney Foundation, so that's part of the reason that they are here, and they play an essential role for those listeners and audience members who have chronic kidney disease or advanced chronic kidney disease. It could be a very, very challenging life. There are a lot of issues to address. We spoke briefly: bone, heart, kidney,
yes.
blood sugar, blood pressure. There's help out there, and the National Kidney Foundation
That's
is
a great
committed to that.
resource, absolutely. Aside from cardiologist, aside from a nephrologist, and you also mentioned an endocrinologist, and of course I mentioned certified diabetes educators, who else do you think is an important part of the healthcare team? Number one being the person with diabetes who is going through this. Who else should be part of the multidisciplinary team in a person's care?
I think that a primary care provider is critical, because you want someone to sort of be the captain of the ship. And particularly in these chronic conditions that each impact positively or negatively on each other, having one person who's in charge, and for many that is a primary care, an internist, a family practitioner. For younger women, sometimes it's their gynecologist, to really keep track of all of the issues along with the individual, the patient.
That's very interesting. As a cardiologist, do people sometimes ask you to be their primary care physician?
They do, and there are many cardiologists who practice both general. I personally do not, but many do.
Because you're so wonderful. I could see people wanting you to be their primary care physician as well. Is there anybody you would add?
I would only add, in strong agreement of that, is when patients don't have a primary care provider, sometimes they have to decide, well, which doctor am I going to call? I have a headache, or I have this. Am I going to call my cardiologist, my nephrologist, my endocrinologist? And people shouldn't have that burden. They shouldn't have to triage their own symptoms or their own health decision processes. They should have someone they could call. And the other side of that coin, which is a reality, although it's not nice to say, but you may call your doctor, and your doctor, in so many words, is going to say, well, that's really not for me. It's not what I do. So this patient or person is spending a lot of time triaging their own issue. A primary care physician is really an invaluable tool.
I agree. It's very, very important and very challenging for people who may be going through a change in their life or in their job or in their marital status where insurance changes. And that's a talk for a follow-up conversation. We have another question coming through about physical activity. How do you engage somebody in starting to be physically active who may have a fear, perhaps because they do have heart disease and diabetes? What do you suggest for them to just get started?
Yeah, knowing that this is physical activity is certainly not an all or none sort of opportunity. Sitting with your clinician to take a look at your overall health, your heart conditions, your blood pressure, whether there are any orthopedic or bone abnormalities, and let a physician, your clinician, know that you know how important getting physically active is, and then truly with them coming up with an opportunity. Physical activity is walking 150 minutes a week in 10-minute intervals. It's climbing steps more. It's not buying expensive clothing. It's not looking to run the marathon in the fall. It's literally choosing to move more.
Just
and
choosing
everything counts. Everything is in the right direction.
A little bit more, and something that can be very encouraging for people with diabetes is to check your blood sugar more often when you begin to be physically active, because as that number goes down, that's very encouraging.
Absolutely.
You feel very accomplished and very good about what you're doing. Even if I love gardening, so even something like gardening, and it could be walking your dog if you're a dog person. And you mentioned before doing it with a buddy. Sometimes a buddy, a coworker, or a friend, or I mean, to me, my buddy is my dog, but whoever you're going to be walking with can be wonderful. And walking is not always the answer for people who may have bone, orthopedic, or problems with their feet. You know, and that can be part of the microvascular disease that happens with progression with diabetes over time. But the encouragement of seeing something move, like your blood glucose levels improving, can be tremendous. And it could be something like dancing or whatever floats you, swimming, whatever works really, really well. Dr. Winston, in terms of people who are first diagnosed with kidney disease and it comes out of left field, how do you help them navigate those waters?
I I look at what the opportunities are to get better. And I think that's where one has to, that's what doctors, I think, should be doing. And it's easy to talk about, not all kidney disease is black and white. Having kidney disease is not the end of the world. And there are always opportunities to get better. And that's what one has to eventually get to. When it comes out of left field, it's always tough. And I certainly try not to break it to people so that they feel it's coming out of left field. But I often see people in second opinions, and they're already shell-shocked. And thankfully, I'm well-trained. I know what I'm doing, and I think we have to always explore opportunities to get better. I know that's what Dr. Rosen has been talking about. We're both talking about that, and that's really how to go forward.
We could definitely feel your compassion and your passion about this. Is there a difference in people who have diabetes and chronic kidney disease, who have type 1 diabetes and type 2 diabetes? Are the treatments different, the outcomes different?
There's certainly different treatments for the diabetes per se. There are, right now, not that many different treatments for the kidney disease as a complication. But for people who are listening, generally speaking, the type 1 diabetics are younger, and their challenges are different than a type 2 diabetic who may be considerably older.
And Dr. Rosen, is there, before we wrap up for the day, please share anything else that you'd like to share with our audience. You had so many pearls of wisdom today, but if there's anything else you'd like to share with us.
I think don't be afraid of finding out information. Again, knowing what your risks are and knowing where the opportunities are to get better is really key. Feeling empowered, prioritizing how you choose your clinician.
Yes.
That is one of the most important partnerships in your life.
I completely agree with you. That's wonderful. Anything else you'd like to share, Dr. Winston?
I agree. No, I agree 100%. I think the mission, part of the mission, is for us to have partnerships. It shouldn't be doctor-patient. It really is partnership. We're on the same side. We want you to get better. And working together, there are lots of opportunities.
Absolutely true. Unfortunately, we've run out of time, and in case we didn't get around to answering your specific question here, please check back on the National Kidney Foundation's Facebook page, where we will be posting answers throughout the coming days. Now, on behalf of our partners at the National Kidney Foundation, Diabetes Sisters, and WomenHeart, I would like to thank you so much for watching, and I'd like to wish you all good health. Thank you guys so much. It was great.